This week on the BackTable podcast.
You're basically having to go really quick and suctioning so you can get a glimpse of where you need to direct your scope, which is one of the reasons why I decided to have a proximal to distal light source on that Vie-Scope, because I've been burnt so many times with using other devices and going blind that I thought, well, if we could shine that light down the sidewall and down the lumen, even if that blood sort of like came up the tube, if I suctioned it back out, will I still have enough light to see the target? And the answer is yes.
Hello, everyone, and welcome back to the BackTable podcast, your source for medical innovation. You can find all previous episodes of our podcast on iTunes, Spotify, and at BackTable.com. This is Eric Gantwerker as your host this week, pediatric otolaryngologist in academic practice in New York. Here we talk about physicians and entrepreneurs innovating in the digital health space. And today we have the honor of Nilesh Vasan with us today, and fellow otolaryngologist. Thanks so much for coming on.
Hey, thank you very much for the kind invitation.
Of course. So how would you describe yourself to somebody who isn't a doctor and doesn't know anything what you do?
Well, I'll say I'm born and bred in New Zealand, which explains my accent. And so you don't need to have something like Google Translate to basically understand what I'm saying. But I'm an ear, nose, and throat surgeon, medical school, trained in New Zealand, and ended up in Oklahoma City and faculty here, specialized in head and neck, and here with my wife and two boys.
That's awesome. That's awesome. So what sort of got you to the point of being interested in ENT in the first place?
So my interest initially was orthopedic surgery for whatever strange reason. And I think it was that sort of carpentry and making use of very sort of heavy tools that got me interested in that. And then one of my classmates back in New Zealand, he did a selective in ENT. And funny enough, he became the orthopedic surgeon and I did mine in orthopedics and I became the ENT guy. So we sort of crossed paths. And one of the things about making up my mind was, unlike, what usually happens in places like the Commonwealth, where you sort of graduate and then you specialize by doing some rotations, I actually came up with the decision to follow the ear, nose, and throat path in my last year of medical school, which is like typically what happens in the United States. They've got to somehow make a decision, even though they've not experienced everything, and then just, roll with it. So in my final year, I sort of figured out, hey, maybe orthopedics is not quite for me. And then met some very cool ENT people because we were all cool and they're all sort of pretty laid back and they're all quite helpful. And I think that plays a major influence in your decision making.
For sure. So you followed the Mike Rutter, New Zealand, going into orthopedics, going into ENT path.
Well, yeah. Well, I know Mike fairly well. He graduated the year I entered the program. So we all met up at a conference and he was giving a talk about, his experience as an ENT. And there I was just about to enter.
That's so funny.
It is. Yes. You can't miss him with his Hawaiian shirts and stuff.
I know. Seriously. Also a fellow entrepreneur. We had him on the show, actually. So you'll be the second ENT from New Zealand on the show.
Oh, cool.
So you went to training in New Zealand. You trained in otolaryngology. And then sort of what was that next step for you and what brought you to, of all places, Oklahoma?
Well, my wife is actually from the US. And after we got married, we lived in New Zealand for about 6 years. And I think, subtly, psychologically at night, she must have been whispering in my ear, you're going to go to the States or something. And ultimately, when it came down to a decision to specialize in head and neck, the only, I think, in my opinion, places to really train were in the United States with, an American, head and neck society type fellowship. And cut a long story short, by more fate than anything else, I ended up in Oklahoma City with Jesus Medina, who took a gamble on me. And then after I left him to go into private practice, he sort of worked the slow game and lured me back. So, yes, I've been in Oklahoma City as faculty since 2008.
That's crazy. So as you sort of transition from private practice into sort of an academic, was that a tough transition for you or was that sort of second nature?
No, it would have been tough if I had hung on into the private sector. The one thing that I think most people, maybe we can talk about this later, is your volume of cases. So I was doing head and neck in the private sector and I had residents and things too. And, we were doing composite resections, all the things that you would think about that a head and neck surgeon would undertake. But the volume wasn't there. And I thought, well, after a number of years, my skill set's probably going to deteriorate. And then you probably feel less comfortable and confident in tackling these cases. And I thought, well, at some point, you're either going to continue down that line and probably forego those operations, really complex ones, especially if you don't have the multidisciplinary team with you when you need them, or make the jump into a faculty practice where everyone, the resources are there, the setup for performing those operations and actual management of those patients in the long term. So I think everything sort of transpired at the right time back in 2008, except for the recession. Note to anyone that's listening, try not to move during a recession.
I moved during COVID. It was even better.
Oh, good grief. Well, that's a whole nother story as well that we'll probably touch on. But yes, Dr. Medina he was my mentor and obviously became a very good friend. And we've always stayed in touch over the years. And Oklahoma's always had a special place in my heart. I remember having the interviews. It's a long story, but the quick scenario was that I was looking and, since I wasn't a citizen and from a medical school in the States, I had to go off the match. I was meant to take this position in Florida, which didn't transpire. But the guy called me up and he goes, you need to speak to this guy, Ashok Shahar Memorial, and he'll tell you what's what. So I ring this guy and he goes, oh, Nilesh, there's only 3 places. You got A, B, and C. I suggest you just go over there and visit them. And I visited 2 and I had my 3rd one over the telephone with Dr. Medina. I think he was talking to me while he was operating because every so often he would say, stop. Were you talking to me? No, I was talking to somebody else. And so,
oh my God.
So I had this phone interview with Dr. Medina and he asked me all the right questions. I think I must have impressed him somehow because I wasn't face to face. And, he hired me and the rest is history.
That's incredible. So you're now doing a fellowship working in Oklahoma and you start getting ideas, some of these entrepreneurial ideas. And so take us through that process.
Oh, sure. I think as physicians, we all have ideas. The question is whether or not you act on it. And I had ideas in medical school. And I remember because depending on who you talk to, those are the people that could either make or break you, in terms of encouraging you to pursue ideas or just encouraging you that you're on the right path, the way to think outside of the box. And then perhaps later you might come up with an idea that actually might, fly. So I still remember when I was interested in orthopedics, I was wondering about the issues of hip fractures, for example, and why you put these prostheses in, but eventually you have to replace them due to all these fractures that you might get. And it was crazy. I was a medical student, really dumb. And I thought, well, why can't they just have something like a suspension mechanism like you have in your car or something like that? I just sort of spent a day just drawing out all these pictures and stuff. And I went to this orthopedic surgeon and he just raised his eyebrows and said, my God, you're one crazy fella. Disparaged the whole idea. And I felt quite deflated after that. And then I didn't really give it a shot until later when I had a little bit of time on my hands, experienced a lot of different things in ear, nose, and throat, complex problems. And I started coming up with ideas and, jotting them down. And interestingly enough, I didn't do that in any of my ear, nose, and throat training. I did it when I was in private practice. And, maybe one afternoon or on a weekend, something would light up in terms of an idea. And I had the wherewithal to write everything, sketch diagrams, and then most importantly, have it notarized because it gives you a timestamp, which might play into when you sort of get ideas in university versus outside of it. So I came up with a few ideas, a few for sporting equipment too.
That's awesome.
That didn't fly at all because I sort of sucked at a lot of sports and I thought, well, maybe this would make me, perform a bit better. Regardless, it was all in the same magazine and I sent it to an attorney up in the Northeast when I was up there. And he was really kind as well. He said, all your ideas are rubbish except for this one. And I thought, which one's that? And he goes, this medical device thing where you try to help people breathe. I said, oh, well, I suppose that's something. And I didn't do anything with it until, got back to Oklahoma. And finally, you raised enough reserves to maybe take a risk.
Yeah. It's such an important thing, too. And we'll talk about this a second because, when you gave our grand rounds, you specifically talked about the day one agreement. So we're going to talk about that in a second. But, what gave you the foresight to know, I need to sketch this out. I need to write this down. I need to get this notarized.
Yeah. Like I said, I've been aware of how some of the ideas, and no means am I an expert. I'm truly novice. Right now, people do MBAs and they go through, of course, I'm living my MBA by the hard yards, by making mistakes and occasionally getting a win. But at the end, I thought, well, the whole thing about the idea is that there's a chance that it may become patentable. And for a patent to occur, you've got to have a time where you might have actually come up with the idea. And you don't want to make it public. It sounds not very nice, but if you make it public, you can't really patent anything because it's in the public domain. So I knew that much. And so I sketched out all my ideas, not just because I wanted to put everything down, but I thought I might forget. And then with time, maybe make some additions to those ideas and then come up with maybe a workable concept. And when I look back, and I still got that old composition handbook, like, you get for 50 cents or something at Staples, and I still have it, and I've got all these ideas in it. But this is the one that actually turned into a company, the Airway device. And the reason why I came up with that is because I'd seen so many people struggle with airways or potentially lose them, and then the morbidity, the mortality associated with it. Whereas if we're around, they might ask us to assist or be there from the very beginning. And just using our tools made it so much easier, I thought, hang on. Okay, you guys, you're going to try taking on this case. You're going to use what devices and tools that you've got. And, sometimes it works out, but oftentimes it doesn't. And then they might ask us to just, stand back and they look at you. And then you have to do your thing. And it's either going to be like a cryo and a wake trach, or you use your anterior commissure scope to get access to the airway and pass a bougie down there. And I thought, well, that seems relatively straightforward, even in cases where people think it's near impossible. So if I can do it and everybody in ear, nose, and throat can do it, why can't people outside of our field have that opportunity? And that was the impetus to make, say, essentially a self-contained, battery-powered device that you can keep in your pocket and you don't have to be in the operating room.
Yeah, for sure. And for those who aren't ENTs, what does an anterior commissure scope do?
Well, an anterior commissure scope is a metal device. It was actually the first true direct laryngoscope, if you think about it. But it's an enclosed barrel, and it's got a flanged open end. And ear, nose, and throat surgeons essentially use that device for diagnostic laryngoscopy, assessment of tumors, taking biopsies to make a diagnosis, or mapping out certain lesions within the larynx or pharynx before we engage in some sort of therapeutic management plan. And it's a bread and butter of ENT. Direct laryngoscopes of that design have been part and parcel of ear, nose, and throat since it's the field's inception. And the one thing about the device that we came up with, it actually mirrors Chevalier Jackson's anterior commissure scope from 1925. It's not like an ultra fancy device with a monitor and all these bells and whistles. It's a really simple tool to be used in incredibly complex situations.
Yeah.
Because the more complex it is, sometimes that you fall over yourself just dealing with that as opposed to managing the problem. And that's essentially how it was born.
Yeah. And you're right. As ENTs, especially when we get called for airway emergencies, it's always the question, and you brought this up in the grand rounds, was, do I have more skill, or just do I have more tools, or do I know how to use them better? And so, the anterior commissure scope has saved me many a times in some difficult airways, which is sort of where it's really opportune. But was there a specific patient case or specific moment you remember, like, I have to do this?
I think I had a series of patients, and I can't remember where now, but all over the place. I've been practicing for 25 years now, and it leaves an impression, not a good one, in terms of dealing with these patients. And you don't forget. And then you have to ask yourself, what could you have done better? What could you have done to make this a difference and not turn the situation into a complete cluster? And it's not just us, I think, coming into a case, but even when we are asked to assist. So I've had patients, who in the emergency room or up on the floor, my colleagues in the other room have a difficult intubation. All of a sudden it's traumatized, is bleeding, they lose the airway, we got this can't intubate, can't oxygenate sort of scenario. They're pushing all sorts of panic buttons. And you do what you do, you roll in there to sort of assist them. And then you use your anterior commissure scope because, we can use the left hand and the right hand. We've got no dogma. You can use the left side of the mouth, for example. We've got a lot more versatility, I think, and we're not bound by certain, I think, artificial rules. So we make it get to the airway. And then we just have to do a Seldinger technique because it's much easier to pass a 5mm bougie than a size 7 endotracheal tube, right? And
100%.
Right. And then you can nail the airway and you usually save the day. And a lot of people know that, Eric. It's like one of the first places that utilize this scope is Johns Hopkins. They developed their difficult airway response team, the DART, and they put the metal anterior commissure scope with the light box and cable on their cards. And, and it's Dr. Barty and his team over there that brought that on, and they've researched it. And that knocked down out of OR crikes by, over 50% just by having otolaryngologists involved in airway management in the hospital. And I thought, well, you think about that. What would our paramedic colleagues, respiratory therapists, CRNAs, small rural hospitals on the outskirts of Oklahoma that may not just have, a video laryngoscope in every OR or in the recovery room, they have budget constraints. So there's lots of different groups internationally and even in the United States that I think could benefit from different methods of accessing the airway.
Yeah. We're going to talk about pre-hospital and sort of the market for your device and specifically why you chose pre-hospital in a second. But I want to take you back to that moment where you had the idea, you sketched it in your notebook, you got it notarized, you sent it to this guy. This guy said, I like this idea. All the other ones are crap. What's your next step? What did you tangibly do after that conversation?
I did nothing, which I think is typical of any physician entrepreneur. I'm not talking entrepreneurs. I think you meet a lot of different people. And the wonderful thing about entrepreneurship in general is that you just meet a whole different group of people in all different spaces, in terms of tech or whatever it may be. And generally speaking, everyone's ultra helpful. And the one thing that entrepreneurs have to go do is fundraise generally. And that's the rate limiting step. And at that stage, I was coming over, young family, and I had no idea about the fundraising aspect of it. And then I made a mistake too, because once I started getting up here into Oklahoma and had some funds, I did start the patent process in earnest. So it's only once I got here, I got settled, and I thought, hey, that idea that I had many years ago, maybe it's the time to act on it. And I delayed it by a while because I thought you got to have a patent first before, you can actually talk to people and do anything or make a prototype and have that proof of concept where you can show it around. And it was actually a device rep over here who kept on asking me about it. And he goes, what are you doing? I said, I haven't done anything. Have you submitted your patent application and this, that, and the other? And I go, yes. He goes, you're just wasting time. It's going to take years and you're just sitting around. Whereas right now, while that's going through that process, you could start thinking about building your deal and refining it. And then you don't have to waste more of your patent period after getting a patent, which was really sage advice because I had 5 office actions for my first one. I had an incredibly hard patent examiner who, even with my New Zealand charm, couldn't win her over. And it took a long time, but in a roundabout sort of way, and maybe I just do this to make myself feel better, she helped me because, she was finding all these holes. And one thing that people have to understand with the patent office, whenever you have a novel idea and you submit your claims, all the things that make your idea different, the patent examiner will conjure up a bunch of different patents and say, hey, buddy, I put these 5 patents together. I get your idea. Come on, it's not novel at all. And then you have to go like an attorney because you've got the medical background and read all those patents and basically say, no, it's not like that at all because, patent A says this and ours says that. And it's a long deal that costs a lot of money. And the other thing that people need to realize is that you get what you pay for when it comes to patent attorneys. And I used a top firm. That's all they do is they specialize in patents and have a group of people with medical device background. And they help you, but they don't really know the crux or the intricacies of your own device. And you're teaching them while they're teaching you. And you've got to have a really good relationship with those people. So I got that process going. And you can imagine the amount of money that you burn through. And I took that other fellow's advice and I started working on prototypes, 3D printed prototypes. I was introduced to people like electricians or electronics people in Oklahoma City. They were kind enough to humor me by actually making this stuff. And we came up with some devices and the fundamental design, which still carries through to the final product today. And that's how we got the device and got it made so we could utilize it on a mannequin and show people. And by the time that sort of happened, our first patent came through, a utility patent.
And up to this point, have you been bootstrapped? Do you have other investors? How did you fund this efforts?
So I funded it myself for a long time. And the other thing is that you got to have a very understanding spouse, right? Because I've got a very understanding wife and she understood that I had this passion. And I don't think she quite sort of saw that it might have potential. And she probably still thinks that way, but we'll see. But you want to make a difference. Ultimately, the whole idea behind this company is I don't want patients to suffocate to death. That's pretty much it. And I don't want them to suffocate on the street, in a hospital, on the floor, or anywhere where someone could potentially lose their airway. And when I first came up with the design with the team, which developed after a while, I thought, well, this device is I think, ideal for military, like special forces or whoever, because those guys have to run in small teams and they have to carry their own laryngoscopes. And if their own, colleagues go down, they have to know how to do everything. And then I thought, well, I can't even imagine that. What sort of scenario would you be in, potentially a conflict zone and having a horrific, maybe head and neck injuries or whatever, and still, hopefully being able to nail it? And I thought, well, we better build this device in case if it goes down that route, it could withstand all the beatings that it's going to get, dropped from great heights, submerged for long periods, all that sort of stuff, which is what we did. In fact, my co-founder, Paul Hagen, who started off on this journey with me and who's my guy on the ground 24/7, made some videos where he runs over one of them with a fire truck and then uses it afterwards. And it still works. At the end of the day, we're thinking ahead. The last thing I want to have ever happen is device failure. And sometimes you have devices that are really expensive. It doesn't work. You're in a hospital, you just get another one. But if you're out on the street, you might not have that luxury. So there's a long line of things that we had to get right before getting this out on the market. And design is one thing, manufacturing partner, and then having all that happen requires money. So getting back to your question of bootstrapping, yeah, that's what we did. Initially, it was my wife and I that funded everything. And we got to a point after obtaining some patents, the device, the prototype, and in fact, going to an EMS conference with my colleague and co-founder, Paul, who basically on a phone call, and I was introduced to him, he goes, well, you seem to have a really cool idea. Why don't I just come to this conference with you and we'll try out this prototype with all the folks there and we'll see what happens. And we had this awesome response. And he goes, man, I'm in.
Yeah, he saw the response, right?
He saw the response. That's the proof of concept, right?
Yeah.
These booths that you have to purchase, the flights, everything all costs money. And a lot of times people don't want to do that. And that sort of nixes the idea there and then. But I took the risk and we both went down and it was wonderful to see people's responses. You could tell the people that they're sort of a little bit stunned because at the end, they may have lost somebody. And then they think to themselves, man, if I just had this thing, maybe I wouldn't have.
1,000%. So as you go through that and you have this proof of concept you did 3D printed, now as you think about scaling and you think about funding, there's so many roads that people can go down, right? They can go down the angel investor, the VC funding. We can go down the SBIR. They can even go the academic route. They can go an incubator route. What sort of other avenues did you investigate before you sort of finally decided how you were going to fund your entrepreneurial effort?
Well, the whole thing about the United States is that there's certain areas that are way more mature than others. And I think the majority of places for health sciences are on the East and West Coast, and maybe even down in Texas and Dallas and Austin, where a lot of people have set up shop. And you have a certain group of people that are familiar with, medical devices or, biotech, pharma, or all these other different areas. And I was in Oklahoma, and the one thing I did do, with credit to them, is become associated with an incubator here. I think we've only got one. And they gave me an education, learning about how you might raise your pitch deck, how you might present your idea to other people and things like that. And I still connected with them, but, I never received or asked them for any funding. They have term sheets and you have to become a little bit of an attorney yourself to figure out what sort of deal that you might be getting yourself into. But one of the things that they'd organized, which was really funny in retrospect, was a pitch competition here in Oklahoma City. And they said, we would like you to talk about your stuff. And we've got these two other guys. So front up, there was this wonderful venue. And I'm sitting at the table and one guy had this idea, which was a bit like Pinterest. And then this other fella had this Pandora type thing. And I'm sitting there and these guys, they both said to me, man, we feel really bad sitting next to you because look, we just come up with music and crap. And you've developed this thing that might save someone's life. And we're sort of sitting and we're all chatting. And I had the first presentation, I gave it. And then the other two did. And there must have been I don't know, maybe 200 people in the room. I might be over exaggerating, but it was a lot of people. They all flocked to these other two guys and only two people came up to me. And one was a nurse, and she goes, I like your idea. Good luck. And this other fella, he goes, you might have something.
Pseudo validation, right?
And meanwhile, these other two fellas are being swamped. It's like some sort of rock concert, and they're just walking out onto the street and getting mobbed because people are thinking, hey, these guys are going to be the next Google or whatever it may be. And they're thinking that that's where I've got to invest my money. And I don't blame them because of the rapid fire trajectory that a lot of these tech companies have. But for the health sciences thing, you need people that have previous experience. Usually they understand it's a long game that you have to play. It might take years, and because you're dealing with physicians. And, if you ever look at the adoption curve, the physicians are right at the very end on the right.
Late adopters.
They're beyond the late, right? Beyond that. And I didn't quite realize that until, I read Jeffrey Moore's book, Crossing the Chasm. And if anyone wants to read that book, that's fantastic. It gives you a really good idea of how things might work in tech, but it's applicable to any idea that you might sort of start up on. So after I got that initial prototype out and I connected with Paul and I set about refining things. And Paul was based in Seattle at that time. And I think that was good fortune as well as good management, because he had a lot of mentors and associates there that he was bouncing ideas off of. And eventually one of his associates said, well, when are you going to ask me to invest in this company? Because he was a design guy and also was instrumental in the development of the Sonicare toothbrush.
Oh, wow.
Yeah. And he had that background, and he had all the manufacturing contacts. And so our Vie-Scope's actually made by the people that made the Sonicare toothbrush.
Oh, that's cool. I didn't know that.
So, all these concentric circles are getting tighter and tighter. And they introduced us to their design team based up in Seattle. That's Workshop 16 with Jed McCann. And he's an awesome guy because we were doing all of this online, having these evening, Zoom type calls, looking at SolidWorks and trying to refine the design. He'll send us a prototype. And eventually we got to a point where we could produce it. And the only ISO facility that could do that was based in Indonesia. And Paul went over there and spent a week with the manufacturers to refine that device and just iron out all the little kinks in it and made it the device that it is today. There's certain standards for laryngoscopes, and, it's got to withstand 15 kgs, and we made ours withstand 30. There's all these extra things that we wanted to sort of make bulletproof. And that's essentially how it took off. We got to a certain point that you just have your head above water, that somebody can see it. And then you can put your arm out and then they can grab you and pull you onto the boat. And so that's our seed round came from. And that gentleman up in Seattle had a syndicate of people that followed his lead. And that's where our original funding came from. We've had a few rounds, family, friends and things like that, but we haven't gone VC.
Yeah.
And this is still a private company.
Is there a specific reason why you haven't, or are you waiting till you get a little bit of market growth, or what are you waiting for? Yeah,
well, at the end of the day, there's a pros and cons of anything that you might want to do. And I think people are sort of sitting in the background. They're probably just wondering, where's this company going? A lot of people like to sort of take their time before they might engage, but we know a lot of people. Ultimately, the device is a bit different. The whole thing about Airway is that even though ENT are asked to come in infrequently, but at the worst possible times during a patient's airway issue, we don't hold ourselves out there as being the airway experts publicly. Even though maybe privately we know that we can handle pretty much everything, both in children and in adults. But it hasn't really been a thing up until the last few years. Academies this week in Nashville, and, usually now they might have 2 or 3 instruction courses on difficult airway management, because our approach to airway is completely different, I think, than lots of other groups. And I'll give you an example. When I started really getting into this and we were researching it, if I was to give you a patient, Eric, and I told you, hey, this guy has a tumor, and you knew that ahead of time, I think 99% of the time you would have somehow done a flexible scope or something in the office, and you would have an idea of strategy going into it. But you just think, some of our anesthesia colleagues don't do that, and they go in blind, right? And sometimes it's a surprise. You have to tell them, hey, listen, there's this tumor there on the right side. I know you guys always pretty much go down the right side, but that blade's going to hit it, and it's a friable tumor. You're going to make it bleed, and then they'll make an adjustment or something like that. So what we did was we had a study where we thought, we don't want to have any arguments with our colleagues. Let's get them on the same page as us. Let's scope these patients that are relatively stable. They're difficult airway, but stable in the holding area. And we'll all look at the monitor together. And we had a little template pro forma. And, sometimes you see these massive base of tongue cancers or whatever. And our colleagues are looking at it and they can't identify the anatomy. And the realization hits, okay, well, our tools are going to dig into that mass.
Right.
We need to do something else. And that study showed that we had a 50% change in management.
Holy cow.
Right. It was a small study, but still,
yeah,
it was 50%. And the fiber optic skills, the skill set there is changing, I think, for lots of different reasons. So oftentimes it's my residents, myself, my fellow that are performing the fiber optic, or we use the anterior commissure scope awake using some Precedex or something so they don't lose the airway. So there's a lot of, give and take. And the one thing about our anesthesia colleagues, they've come up with all these airway algorithms, but oftentimes based on the tools that they're comfortable with and have been taught to use. And then if you ever look, I don't know if you've ever looked at these, but almost every country has its own airway algorithm. But if you look at the end, it's things are a mess now. So do anything you can, including rigid bronchoscopy. But I don't think hardly any anesthesiologists know how to perform rigid bronchoscopy. That's us.
Yeah, I've never seen anybody do that from anesthesia.
Right. But it's part of the protocol. And I'm not sure, but I don't think ENT people are everywhere to do that. And I suppose our Vie-Scope is a miniature shortened bronchoscope. So, at the end of the day, you just want a passage. And the adoption rate, we can talk about that if you like, in terms of dealing with different groups of people and what they think is normal versus what you think is makes for interesting conversation.
Yeah. So let's talk a little bit about the market, right? Because anybody who's innovated within ENT and you go to a VC and you say, I have this idea, and what's the total addressable market? And you're like, yeah, about 1,000 people. And they're like, I'm not interested, right? So One of the things that you talked about was the idea of using this in pre-hospital and or military austere environments. Was that a deliberate decision from a market analysis, from a business, or was that more from a use case for what you were trying to develop?
That was deliberate. The one thing, and maybe I was wrong, but things sort of went out of control a lot faster than I expected, is we clearly identified EMS as our primary market because I can't imagine, what they have to do. Everyone's just had a full meal and then they're involved in a car accident and they're strapped to their seat and they're losing their airway. What are you going to do? Right. And it's very different.
C-spine precautions and yeah.
Yeah. I can't even think of that. And I've been involved in some hairy situations too, but nothing like that. And I thought, well, could this device be accepted more easily, early adopters in EMS? And generally speaking, I think so. And it's not just in the United States. So if you talk about intubation, at least 55, 60 million people get intubated electively in the United States per year. And around about 5 million might get intubated on the street, United States. So that's us. And what about the global market? So you just imagine, there's some places that may not have the resources. You can, think of those countries. And then there's other places, Western Europe, for example, where they have everything too. But still, they have a lot of cases. And we know that there's a percentage where it's going to be not easy. How do you help those people? So it transitioned very quickly. So we focused on EMS for the first few years. The adoption was slower because one of the things about the Vie-Scope, for example, is that it's a 2-phase deal and you had to put something on the teeth. So I know I'm speaking to an ear, nose and throat crowd and everyone's thinking, oh yeah, so what? But for other people that are not ENT, that's a huge deal. They have been indoctrinated to not put any laryngoscope on the front teeth or the gum. Otherwise, they're going to have their hand cut off or something. And it's totally against their fiber. And then with the advent of video laryngoscopy, they need to see the endotracheal tube pass between the vocal cords. So these were the two pieces of feedback that we were getting that they couldn't get their head around initially. And we had to counter that. We had to counter that in person with discussion or by making videos. We've utilized, I think, social media. It's a small company, so we make these videos and we put them out there for every question that we might get or to counter the argument. And the reason why people don't want to use these laryngoscopes on their teeth is because they're designed to break teeth. You look at a Macintosh, it's metal and it's right angle. And if you put any backward pressure on the teeth, you're going to break them all. And that's why they push it, cheers with your beers, forward to sort of sweep the tongue anteriorly. And then you have the Macintosh, which is, in the vallecula, whereas, most of us use laryngoscopes like we use a Miller and elevate the epiglottis and see. And then lastly, when it came to the bougie, why do you have to use the bougie? Well, it's easier to pass than say a size 8 tube. And second, you don't have to have a grade 1 view to pass a bougie. You could probably see like 10, 15% of the glottic opening to pass a 15 French 5mm bougie. That's why you do it. And then they can start thinking, because they've never had this presented to them before. And now it takes time for them to warm up to that idea. Like the other thing is saying, well, if you have to use this two-phase approach, you're wasting time. And then we'll say, well, if you're not intubating that person and they're trying to go blue and die, are you going to be like too worried about, that two-phase deal and an extra 10 seconds? And they think, oh yeah, maybe you got a point. So it takes a while. And I think we're down the road enough now, we're about 6 years, just over 6 years with the Vie-Scope, that people understand the concept. It's whether or not they take the chance to try it. And that's the other thing that we have to do, Eric, is we don't get people to pay when they're like for devices. We just send it to them for nothing, just so they can like figure it out for themselves.
Right. Experience it for themselves. Yeah. And so for people who aren't familiar what a bougie is, it's essentially a small tube that goes into the airway, and then you can pass the endotracheal tube over the bougie into the airway. So, but again, it's often used as a secondary measure. It's not usually a first line therapy. Just like when the video laryngoscopes came out, they weren't first line therapy. People were only using them when there were difficult airways. And so one of the things is just, it's a training gap, right? It's a training gap, and you have to teach people like, no, we can actually use these in other settings. And you don't necessarily have to wait until the patient's dire need to use this scope with a bougie, right?
Correct. There was a meta-analysis that just came out, I think it was from South America, that basically says that you should consider using the bougie for every intubation. And you say, oh, why would you do that? Well, you got to be familiar with how to use it. So, if things really do turn to custard, you're familiar with how to like utilize the bougie and effectively, insert it, as opposed to like in situations where you're panicking and now you're thinking about the bougie. The one thing that I've had on my travels, and you mentioned COVID earlier when you were like relocating, is that it changed the market significantly. And the one thing I always say to folks when they sort of like challenge us is that they get defensive and they think, oh, you're coming in with this device to like replace video. There's no way. No way are we trying to replace anything. Because I think as ENT people in general, we approach airway like we approach an operation. I like the fact that this podcast is called BackTable. Your BackTable should be full of stuff, certain tools and forceps and stuff. And then when you do your operation, you might select something from there to help you. Whereas right now, what's happening, there's a certain group of people who are video laryngoscopy advocates, and they're pushing to have video laryngoscopy used all the time for everything. And I like video laryngoscopy and I use it too. But I wouldn't go so far as saying use it for everything. And why would I say that? Because I think as surgeons, we have past experience going from, say, open procedures to laparoscopic procedures, open procedures to endoscopic sinus, which is wonderful in terms of like patient outcomes. But if things go wrong, you might have to convert. And now we're finding there's a group of physicians that don't know how to do that. And now you're having a complication that's not addressed because they just went through their training without doing any open procedures, unable to handle that sort of situation. And the outcome could be bad. Whereas what I'm thinking is, okay, you've got your supraglottic device, you've got fiber optic, Miller, Mac, Vie-Scope, anterior commissure scope, your scalpel, right? You've got all these things. And depending on the day and the patient, you might use any one of those deals to secure that patient. So that's where I come from, because as a person that runs a business, you'd love everyone to use your own thing all the time, but that's a mistake. I don't want anyone to use the Vie-Scope for like really simple cases. It makes no sense. But if they are familiar with it, they're going to recognize certain indications, certain scenarios and situations where that may give you the best chance of obtaining what they call first pass success, nailing the airway on your first shot. Because if you don't get first pass success, the likelihood of patient complication increases significantly.
Yeah, it's so interesting because you have to have all these tools in your armamentarium. I talk with the residents all the time that, it's always good to know a bunch of different ways for doing things, because also you don't know what's going to be at your next facility. So when I was in fellowship, we had something called a Shikani intubating stylet. I don't know if you're familiar with this, but essentially...
I've heard of it.
Yeah, so it was an awesome tool. I'd never seen it before in my entire life. We had a horrible airway, and my fellowship director or my attending at the time was, go get the Shikani. And I was like, I don't even know what this thing is. we opened it up. I didn't even know how to operate it. And we're in this, in this scenario. And sure enough, so it's an intubating fiber optic stylet, which is incredible, right? It's a video stylet. So, it saved us in that. But if I had never even known that existed, I didn't know how to use it. I didn't even use it ever. I wouldn't have known. And so from then on, when fellows started, we oriented them and said, this is a Shikani. This is where we would use it. And then we would do it in like a simulated patient case so that they would know when to use it, how to use it.
Yeah. The thing about a lot of places, like you've got a pediatric otolaryngology background. So, the one thing that frightens me the most is kids airway. Airway in general, and I should have stipulated this at the beginning. I personally and get really anxious dealing with airway. If I'm anxious, everyone else should be changing their pants.
Right, exactly.
Because you just know how bad things could go pretty quick, and children especially so. I'm ultra cautious. You prepare. You want everything set up and ready to rock and roll. If we're called upon, say on call or something like that, to deal with a pediatric airway issue. And I'm always surprised because, they desaturate so quickly. You got to act fast. And sometimes even in adults, they've got no pulmonary reserve. They start to desaturate. And if you read a lot of these algorithms, they say, you got to have 2 or 3 attempts, and then you might want to think about something else. Whereas I'm always thinking, you just got one shot. If you mess that up, you got to do something like now. You see, even now, I've got some pressure of speech just thinking about it.
I can hear it. I can hear it.
It's because you're just reliving all those moments of, I had an interesting patient a long time ago, and this is a video laryngoscope, and the person had an acute problem, and in addition, ileus with bowel obstruction, and they used the video laryngoscope and they intubated the esophagus, and all this gastric contents just came flooding out of the ET tube, and we thought, oh my God, the wrong place. And they pulled it out, and as soon as they put it back in there, they couldn't see anything. There was no camera, there was no light, because the whole oral cavity was just full of gastric material. And so I had to do, for whatever reason, a direct laryngoscope exam on this person for other reasons. And I had it. And I was jumping up and down, give that to me. I'm not as calm as Mike Rudder. And I might have used colorful language and all sorts of things to impress upon people that this is like urgent. And grade 1 view, straight shot. And we did something akin to what they call suction-assisted laryngoscopic airway decontamination. It's called SALAD. And there's a friend of ours, a guy called James DeCanto, and he came up with this mannequin where you flood it and then you try to intubate it. And you have to get a suction device and park it in the hypopharynx or postcricoid area and then use your laryngoscope quickly to intubate.
That's almost like tonsil bleeds.
Well, that's exactly right. Unless you've got one of your residents or colleague got their finger on it, you're basically having to go really quick and suctioning so you can get a glimpse of where you need to direct your scope, which is one of the reasons why I decided to have a proximal to distal light source on that Vie-Scope, because I've been burnt so many times with using other devices and going blind that I thought, well, if we could shine that light down the side wall and down the lumen, even if that blood sort of came up the tube, if I suctioned it back out, will I still have enough light to see the target? And the answer is yes.
That's so genius.
Well, it's just experience. And it's because it's a school of hard knocks. And unfortunately, I've never had anyone, succumb to anything like that. It all worked out. But, it takes a year or 3 of your life. My hair is actually all gray. It's because of you're dealing with these scenarios. And people think I like it. I don't. I deal with it because I think as an ENT person, we have the wherewithal to make up a plan to secure the airway, which is a really tiny component of our entire field. And people sort of can't quite realize that sometimes. You need to get that intubation right so you can do the laryngectomy. We've got a whole day ahead of us.
It's the most terrifying too. It's funny because we talked about Mike Rudder. Mike Rudder was on the show and trained under him for residency. And the way I approach pediatric airway problems is exactly how Mike Rudder told me. And it was, you come in jovial, you make humor, and you lighten the mood, because if you get afraid, you get scared, everybody else does. And your manner with your doing this and your confidence and your demeanor totally changes how everybody else operates in the room. And I credit Mike Rudder for teaching me how to manage those situations. And to this day, I still do it. And everybody knows if I get quiet, it's a problem because I tend to talk a lot. But that was the same with Rudder. If Rudder ever got quiet, you got a problem, right? And he never really gets quiet, right? So,
well, maybe we're the opposite. I can't remember which part of the island of New Zealand he's from. He's probably for the more fancy part compared to me. But he has a certain calmness about him that I can understand. Maybe in Oklahoma, if I was too nice, they wouldn't pay me any attention. But at the end, the outcome is the same. But, there is urgency. And, I sometimes remember watching that. I'm not sure if you're familiar, but there was this woman who passed away in England by the name of Elaine Bromley. It was a tragic case of losing the airway. It happened in the UK, but they got Australian actors and they swapped genders of everybody to make a video about it. And I remember watching it. And if anybody listening, you can find it on the net. And everyone's saying, thank you. Can you pass me the laryngoscope? Oh, thank you very much. And I think, and I was just screaming, give me that, whatever. And like, let's move. You're wasting time. Let's rock and roll. This is one shot. Just do it. And if you ever watch that video, it eats you up on the inside because you know what needs to be done. But the folks that were in that situation obviously were waiting for each other to take the lead. And that's, I think that's one thing about airway management, which is really interesting in the hospital. So going back to one of your questions about addressable market, very quickly, we got into emergency medicine, anesthesia, all these different groups, both here in the United States and overseas. And I was worried that we're spreading a bit too quick. And how do you deal with that? And the one thing is you got to have really good distributor partners. And we identified that one of the other people that's involved with us is a fellow called Claude Nunlist. He's our director of international sales. He has a Rolodex that's pretty thick if people remember what a Rolodex is. And he contacted all his, colleagues that he had done, business with in the past and introduced them to our product. And
oh, wow.
Many of them just, became stocking distributors and understood what we were trying to sort of promote. It took a bit of work. You can't just tell people, oh, this is a Vie-Scope and you use it like this. You have to show them on a mannequin and give them some scenarios as to, how it could be of use to them.
Yeah, we're going to talk in a second about sort of the future of the Vie-Scope and Adroit Surgical. I want to really quick take a short time back. Nobody comes with one idea that automatically becomes a company, becomes viable, starts generating revenue. What are some of the failed ideas and things that you learned about? Because you had talked about them during the grand rounds, about some of the things that didn't work out, that you actually took some steps towards actually developing.
Yeah, I'm also the program director here. And one of the things that was concerning me a lot was all these work hour stipulations. And I thought, man, we basically have to trust our residents to get this down right. And if they forget, well, worse, they make things up, it's not right. Could we come up with some sort of application that could make it really easy and could potentially notify them of work hour violations and making changes to how they might run their week or their day or whatever it may be. And there was a little software idea. And we came up with that. And eventually we funded that ourselves, as myself and some other folks. And at the end, the money, dried up because it didn't have, it had a couple of physician folks that came in with us, but it just sort of died. And you got to have the whole team be motivated to continue to push things on. And if you try to push things on yourself or somebody else does and your priorities change, things can languish. There's a software that's sort of sitting there, nearly done. It's just, I suppose we just have to sort of get off our butts and do it, because we went through the processes of showing people, other colleagues around the country, and the feedback was excellent. They go, oh yeah, you could put this on your iPhone and you have these geofences for the campus and that these guys are in there. And yeah, we could do all of that. And so, that was one particular idea that didn't quite, fly. But this other deal, Adroit, is a really tiny team. And the thing that I think propelled it forward is having skin in the game, putting your own money to get it to a point where other people will think, oh, hang on, he might be onto something. He's got the vision and the passion, and he has something that is not too way out there. This is actually a technique that everybody uses. It's nothing clever about it. It's just a modification of an old tool. People jumped on board. And the funny thing is, as soon as we came out with that, people were started immediately asking us, where's your pediatric device? I said, what? He said, well, this is cool, but we really want something for peds. And, and we had to get to a certain point before we started thinking about, hey, how could we come up with a pediatric? So 2 years ago, we started on that process, and we just released, the baby V.
Oh, that's awesome.
Which is a, modified Parsons 3, which is another get out of jail device that we use.
Oh, that's awesome. Have you gone through the process with FDA and everything with this, or how does that work?
Yeah. So these are class 1 products. We have 3 and variations thereof. The Vie-Scope, what we call the Voir bougie, the only US made 70 centimeter, 15 French bougie with colored safety depth markers. And I came up with that because, like every good dad, you practice on your children. And I had a mannequin, and my son, he was 10. I said, hey, come on, I'm going to show you something, and then I want you to do it. And I took a video of him too.
Oh, I thought you maybe intubated him with the bougie, but this is a different story.
No, I got him to intubate a mannequin. If he intubated himself, he would have been on a path to medicine. But unfortunately, he's not. He's sort of running away from that. So he and his brother, who was age 6 at the time, got a bougie. They used the anterior commissure scope, and he shoved that bougie in. He shoved it all the way down to the hilt. I thought, oh my God, he's perforated the lungs and everything. I thought, well, he's 10, but hey, if he's doing this, what's the chance that in an emergency somebody else is going to do that? And I thought, well, maybe we can come up with a bougie which has some colored bands, because the dimensions, as you know, after about 10 was pretty much the same. That at the green that you stop at the front teeth or the gum, and you can keep it static. And Paul identified this manufacturer in, Orange, California, Truer Medical, Cherie and Tim Truer, who are really awesome, who gave us the time and worked with us to figure out how do you put this type of coloring, which is biocompatible, that can go through the FDA onto a bougie. And the trick was we used food coloring, which has all been cleared anyway,
oh,
right?
God. Yeah, exactly. Yeah.
So all these products in the United States are class 1. And class 1 means that you can just, as long as it's made in a ISO standard medical manufacturing facility, once you register it with the FDA, you can put it on the market, and all laryngoscopes are like that. Once you get to a class 3 type product, like an implant, vagal nerve stimulator, Inspire, whatever it may be, you have to go on a different route and get something called a 510K, the biocompatibility, and you have to go through the FDA approval. And that's a whole different process. A lot more time and significantly more money.
So we talked at length about all of this stuff, and it's been incredible. What's next for Adroit and the Vie-Scope?
So things grow organically. And you see, that's some silly again. I never concentrated on my own people, my crew, right? The ENT folks. I always thought of the EMS, anesthesia, emergency medicine, here, there, and everywhere. And then one of my ENT colleagues said, hey, we're just using your Vie-Scope for direct laryngoscopy. Did you know that? Oh, why? And he goes, well, we have issues with sterile processing. Sometimes a turnover comes through and pieces are missing, parts are broken. Your deal does everything that we need it to do. And, the cost of setting this whole setup or buying the metal anterior commissure scope, which is X number of $1,000, or even just running down to the emergency room when there's an airway issue, it's easier to keep that in my pocket than to get the whole setup with the light box and everything and run down there. And now we're finding a lot of my ENT colleagues are beginning to see it. A, we deal with Airway, of course, but 2, really busy practices are performing direct laryngoscopy all the time. And, we priced our devices so low that I think more than pays for itself if you consider delays in the operating room, reprocessing, repackaging, all the people that you need down in SSD to sort of put things together. And it's the same thing for the baby V, because, I know a lot of folks, and you can tell me, you're the expert, Eric, when it comes to the ped side, that, diagnostic laryngoscopy, tracheoscopy through a Parsons laryngoscope is what folks usually use it for, in addition to, intubation out of the operating room.
Yeah, 100%. And you can think about all the difficult airway carts that we have across the hospital and how much effort it took to get those even at the bedside. And with all of the setup and everything, this is a much more economic and ergonomic way to think about it. We're going to move to some rapid fire questions, and then we'll wrap up.
Sure.
You mentioned a book by Jeffrey Moore. Is there another book that you would recommend people interested in entrepreneurship? And
I would, and I should have brought that book up here, and I've forgotten his name, but it's one of the founders of Pixar with Steve Jobs. It's called Creative Inc. And I'm reading that right now, and it is absolutely fantastic. This is a guy that had an engineering degree that had a vision when Walt Disney was talking about how animation was done way back in the day before you watched some Disney show. And he wanted to have computer generated animation, and it took him like 20, 30 years to get to that point. But ultimately, that book is about dealing with people and overcoming their fears, their tribulations, their concerns about self-preservation, the fear of technology taking your job. There's all sorts of different things that are applicable to, what I'm doing. It's like, I see that mirroring in a lot of people who become overly defensive about, video laryngoscopy, as if I'm out there like, going to
taking their job.
Take it. Well, these video laryngoscopy companies, multi-billion-dollar companies, the last thing they're worried about is someone like myself, right? They've got lots of different things, but you can see it because a lot of these folks have made their name, published a lot of papers. They're on the speaking circuit, and they talk about it. And the tragedy, personally, I think, is a lot of them have tapped out. They think, hey, video laryngoscopy is it. We don't really need anything else. And that goes against every fiber of my being, because when do you say, okay, I'm going to stop learning now? Okay, this is it. This is the best thing we're ever going to have. And now I'm done. The day that arrives for me, I'm going to take off back to New Zealand.
I was going to say, you check out, right?
You check out. And, but that's the thing when you deal with different groups of people and you want them to sort of come around to your way of thinking. And that Creativity Inc. is really easy read and has a lot of wonderful examples that I think anyone reading it can associate themselves with.
That's awesome. The next question is, who in the innovation, entrepreneur, digital health space are you following or interested in following?
I don't know a lot of people by name, but I still have, connections with Mike. Mike was one of the first ENT people to sort of come up with an idea. And the one thing that we didn't quite talk about was some of the ideas I came up with at university. And one of them was an oral retractor system for robotic surgery.
Oh, yeah.
Yeah. And it didn't go very far, unfortunately, for lots of different reasons. But I performed all my TORS operations with that because I found the FK retractor like an instrument of torture. If I wanted to extract some information and get somebody's PIN number, I'm going to shove that into their mouths and ratchet it up. And, it's like $50,000 or something silly now. And I thought, well, we could do something better than that. And I met with Mike at certain meetings and things, and we compared notes. And maybe it's something about being from New Zealand. We're completely isolated. We didn't really have too much. You got to make do with what you got.
Right.
And I think a lot of people like to think outside of the box. And I think maybe that's what they call the Kiwi ingenuity, which is like a term that folks use to, make these makeshift things with number 8 wire, which is fencing wire that we have all around the country to put things together. So, Mike is someone I've always looked up to. And, in fact, when I had that, prototype of the baby V, I rang him and I said, hey man, could you check this out? And he goes, oh, Nilesh, people send me stuff all the time. Yeah, sure, send it to me. And he goes up to him, and the day he receives it, he calls me and he goes, man, people send me crap, but yours is actually pretty good. It's, and I thought that's the validation I need. Thanks, buddy. Well, I'll get on to the next step now. But, we did that with lots of different people, not just here in the United States or with Mike, but with, other pediatric folks here in Canada and overseas. And you need to do that. Whereas with the Vie-Scope, I didn't. I thought, hey, this is a good idea. I'm going to mirror it and I'll just push on. And, I've met other people starting up along the healthcare route, and people just ring each other, cold. I've had a lot of people just email me and say, hey, can we just chat sometime? I've got an idea. And I've done the same. As a big name person to follow, I suppose I can't really, other than the tech people, the tech giants that you feel that everybody knows, a lot of the folks are people just like us, Eric. They have the idea and they're just sort of starting off.
Yeah. I think I've experienced the same thing where I'll just email somebody who's relatively high up or somebody I admire on LinkedIn, and they'll get back to you. It's such a collegial environment. It's not competitive in any way. And Everybody's been really nice in this space. Connecting to you, how do people connect to you and how do they find out more about Adroit Surgical and the Vie-Scope?
All my details are on LinkedIn. The one thing I didn't want to do, and I'll tell you a story, was be on social media. And reluctantly I had to, and I did LinkedIn for a long time. And then I went on that cancer called Twitter, which is absolutely terrible, but you do get to engage with a lot of people in the airway space of different specialties. And I first, was coming out with the company and, I'll challenge them a little bit. And I got beaten down. They would slap me around because they thought I was just a manufacturer as opposed to like a physician. And then I had to out myself. And then I created this handle and I facetiously called it, Airway Legend, deliberately. Just sort of like, because I'm not obviously not an airway legend at all, but I thought, well, let's just pick a name that they won't forget in a hurry. And a lot of it became a lot more collegial and, measured in terms of our conversations. But people are very protective of certain things that are a part of their identity or specialty. And I don't really want to get into that with them. All we do, I think, is offer an alternative and give them an opportunity to try something different. If you're waiting around for an ENT person to perhaps, salvage a situation and or cut the neck open, and you've never done that before, what's stopping you from doing it? Nothing. It's just the willingness to want to learn something different.
Well, Nilesh Vasan, thank you so much for being on. It was such a pleasure. Please connect on LinkedIn if you dare, and Twitter if you dare. Thanks so much for everybody for listening, and we really appreciate you coming on.
Thank you very much for the invitation, Eric. It was a pleasure. Wonderful.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at BackTable Innovation on Instagram, LinkedIn, or Twitter. BackTable Innovation is produced and hosted by Brian Hartley,
Aaron Fritz,
Diana Velasquez-Pimentel,
and Eric Gantwerker.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening.
See you again next week.